So since we haven't had enough of medical marijuana talk, to get right into our topic. So before I switch gears, because having learned yesterday, that the two preceding presenters were talking about medical marijuana, and most of the slides seem to be very similar. So I'm actually going to switch gears and talk primarily about palliative care, end-of-life care, and pain management. But just a little bit about my perspective as a palliative care physician working at Moffitt, which is one of our tertiary cancer centers. And when patients come in, especially after the Amendment 2 passage, come in and ask for, inappropriately so, but ask for prescription of marijuana, asked to be started on marijuana, etc. So my take and how I respond to that, I just want to share a few things about it. Up until now, when patients actually came and asked about, being started or wanting to do marijuana or being given marijuana, the standard response, and I think this was the standard response by most physicians, the standard response, either because of the lack of knowledge or because there is a dearth of studies or limited studies that is available, the common response would be there is a lack of scientific knowledge pertaining to marijuana and its use in some of the patients' conditions and illnesses. That was the standard response. But after Amendment 2, and having been faced with multiple questions by patients, and also after having taken the time reviewing some of the available, limited but available studies, it is fair to say that there is some evidence pertaining to use of medical marijuana in some of our terminally ill patients or in certain specific conditions. But certainly, it's not what the proponents would want us to think, that there is strong evidence, there is extensive evidence. So it is fair to say there is some evidence, but not what the proponents have us believe, that there is extensive knowledge about it. At the same time, when you talk about safety issues, risks of being on marijuana, it is equally important to say it's not exactly true what the opponents say, that it's scary, that there is tremendous amount of side effects. So it's fair to say there is definitely some amount of side effects known. There is certainly some issues about safety concerns, which is valid, but not certainly to the extent what the opponents would want us to believe, that there is, it's all scary. So I come here without having an opinion one way or the other, just to kind of let you know that this is going to be up and coming field. It is at this point still thought to be an investigational drug. And instead of us saying there is nothing we could do at this point, the only thing that I can advocate for is, since it's still a Schedule 1 agent, to be able to push for better research, to be able to answer the question, is there conclusive evidence? We could at least fight to actually have it downgraded, I don't know if that's the right word, at least have it rescheduled instead of a Schedule 1 drug to actually have it Schedule 2 or down below, or basically eliminate the scheduling. This enables us to be able to do better research on this particular agent to see if there is truly all of the evidence, have better safety and efficacy studies pertaining to marijuana. So later on, if time permits, I will quickly go over the limited available studies, some of the concerns, and the position statements by most of the medical boards. So now switching gears, let me just get familiar with this thing.
There we go.
Thank you. So I primarily will talk about no disclosure. I have no affiliation, academic center. So primarily I'm going to talk to you about end-of-life care, palliative care, and pain management. Often, end-of-life care, palliative care, hospice care, terminal care are all interchangeable. Truly, what we are hoping to do is move the terminology from being called hospice care or terminal care, because of the negative connotation that it adds, to actually call it palliative care. Also, to basically say palliation or care for a person who has advanced illness care for a person with terminal illness does not start at the very end. It starts when the patient is actually diagnosed with such terminal illness. So, those are all some of the things we're going to talk about. So, palliation or palliative care. What's the definition? This is the WHO definition, which can be read. It's basically an approach that improves the quality of life of patients and their families who are facing life-threatening illness. If I have to just summarize it, the shift of care, the focus is no longer on the disease. The focus is now on the patient with the disease, the patient and the family as a unit. So the focus is no longer just the disease. It's not the diabetes, it's not the cancer, it's the patient who's suffering with cancer. So the shift is basically an aim to improve quality suffering in those patients who are living with a life-threatening or a terminal illness. It's often simultaneously offered with other curative treatments. So this is the conceptual shift in palliative care which is being pushed forth. Up until this point, the one on the top is thought to be the previously held traditional concept, and the one below is what we propose, what we are hoping to advocate, and more acceptable, the newer concept. The thought is you don't bring in a palliative physician, or you don't start palliation when everything is done and the patient truly is at the end of their disease process. You start the concept of palliation, the concept of discussion, the quality and the suffering and all of those discussions needs to happen at the time of diagnosis. So palliation starts off at the time of diagnosis of a terminal illness or an advanced illness. So initially, obviously, with any new diagnosis, the focus is mainly curative. But as the patient passes through the stages of illness, the shift, it changes from curative focus to more of a palliative or a palliation focus. So this is the newer concept which we're hoping to advocate. We're hoping that the palliation or palliative physicians are brought on early on in the patient's disease process. So when we talk about pain management, it's important to know what's the prevalence of pain in patients with advanced illness. If you look at all of the diagnoses, these are all the diagnoses most often seen in patients who are admitted to hospice. The CHF, the COPD, the end-stage CKD, the AIDS, the cancer, the CHF, all of those, the blue line is the one which is basically pain. If you notice, pain, dyspnea, fatigue, anorexia, weight loss, etc. are the top few symptoms seen in almost all of these terminally ill conditions. Not necessarily just in cancer, it's actually seen in all of those conditions. There was actually a review article about symptom prevalence in patients with incurable cancer. All they did is reviewed all symptom prevalence articles and tabulated to see what are the more common symptoms presenting in patients with cancer. They classified them into two groups. Group 1 was essentially anybody with the diagnosis of incurable cancer. If you look at that group, pain was number 2. Approximately 21 in all of the studies, they found 71% of the patients, the pooled patients with cancer, 71% of them complained of pain. If you look at those patients, the same in the second group, if you look at the second group, and the second group was basically patients who had just 2 weeks to live. So in those patients, pain still was one of the more important symptoms, but it was like the 5th symptom, but it still was one of the more common symptoms noted. So having said that, as an introduction to pain, despite all what we hear about the opioid crises, about there being easy availability of opioids everywhere, it is important to still note that pain is still thought to be undertreated. It's still thought to be an important public health issue, a problem, and depending upon the study you look at, depending upon the article you read, the numbers in terms of poorly treated or undertreated pain, numbers anywhere from 90% of the patients noting that their pain was uncontrolled to more than 50% of the patients noting that their pain was uncontrolled. especially in the cancer population. If you ask a cancer patient, almost 90% of the patients with cancer note to have had uncontrolled pain at some point. But if you actually look into it a little bit further, if you look into some of the numbers, most people say, meaning 1/3 of the patients note that their pain was poorly controlled or uncontrolled or severely, that they were in severe pain during the course of their illness. 1/3 of not being treated properly is a huge number in any other medical field. In any other medical field, if you look into side effects or statistics, anytime it crosses 10%, it is thought to be a big number. So if we are saying that there is about 30 to 40% of patients who are poorly treated, that's a big number. Based on what we have available to us, without having to worry about sending the patient to a pain specialist or a palliative care specialist, simply looking through the guidelines available to us, whether it's the NCI guidelines, the AMA guidelines regarding pain, whether it's the American Pain Society guidelines, American Geriatric Society guidelines, so AMA guidelines, so there are enough guidelines available and easily available on Google especially. If you just follow those guidelines, the WHO guidelines, if you just follow those guidelines, it is thought that all of us could do a much better job in terms of managing pain, upwards of 80%. So there is a huge disparity between what we could potentially do just by following the established published guidelines and what we are actually doing. And hopefully this conversation today will help to bridge the gap of the two, so we could enable ourselves and educate ourselves to be a little bit better at managing some of the patient's pain, especially in patients with terminal conditions. So I'm going to skip through some of these slides in the interest of time. Pain assessment is no different from doing an assessment of any other medical condition. It's the same thing. Where is the pain? How is the pain? When is the pain? So, I'm just simplifying it. So pain assessment is a good history and a physical examination is what's needed to accurately get a complete pain history. So pain is still subjective, so the gold standard is still what the patient says, but it's equally important to do objective assessment, meaning see what the patient can or cannot do because of the pain. So having said that, we do need a way of tabulating or a way of checking into what the intensity is. We do need a way of calibrating the patient's intensity of pain. There are many scales available to calibrate or evaluate the intensity of pain. Evaluation or tabulating the intensity of pain can be done using any one of these unidimensional pain scales. The more common one that everyone knows is the numerical pain scale, wherein we tend to say 0 to 10, 0 being no pain, 10 being the worst pain, where are you? So that's the more commonly used scale. That's the numerical pain scale. Validated, easily, you can use it at the bedside very easily, quick, efficient, and has been used or has been validated to somebody at the elementary school education. But any one of these pain scales can be used as long as you use the same pain scale in the same patient for follow-up. So, having talked about that, it's important to know that pain, there's two. There's acute pain and there is chronic pain. The thought is acute pain is basically a protective mechanism built in so we eliminate the risks. So acute pain is actually a protective mechanism. The chronicity of pain or chronic pain is actually thought to be maladaptive behavior in a person who has uncontrolled pain for long periods of time, wherein there is a thought that the brain and the glia, there is rewiring, wherein there is more of an output of pain hormones. So people actually consider pain to be serious, and actually they take that into consideration. So it's important to understand that acute pain is a protective mechanism. Chronic pain is actually thought to be more of a maladaptive behavior. Going back to in terms of different characteristics of pain, when patients complain of pain, they say they have sharp pain, they have dull pain, they have achy pain. So looking into the different kinds of pain, it's important to know the pain can be classified broadly as nociceptive pain or neuropathic pain. Neuropathic pain is purely pain due to direct injury to the nerve. It's injury, insult, inflammation, anything directly to the nerve is neuropathic pain. Anything to the bone, the joints, the connective tissue, the viscera, etc. is nociceptive pain. So the nociceptive pain can further be classified as somatic pain or visceral pain. Myocardial infarction is a very good example of visceral pain. Somatic pain, fractures, joint pains, etc. is a good example of somatic pain. Most often people with somatic pain, the pain is usually fairly localized to the area of disease or the area affected. Somatic pain, most often people say it's dull, it's achy, it's throbbing. That's the picture on the corner. The visceral pain is usually less localized. Again, a good example is myocardial infarction. It doesn't always have to be along your left lateral chest wall. It could be upper back, it could be left arm. So visceral pain, so often there is usually a referred component to it, is less localized and usually involving any of the viscera. So that's the visceral pain. Neuropathic pain, most commonly people complain of sharp pain, stabbing pain, shooting pain. The terminologies they tend to use is it's fire, it's pins on needles, they can't step on something because it's really burning. So those are all some of the common terminologies used in patients with neuropathic pain. Coming to management, just like managing any other disease, managing pain comes down to treating the cause. You always try to treat the reason why the patient has pain. But unfortunately, it's not always feasible to treat the cause on every one of these patients. So because it's not feasible, or there is a time delay between what you can do therapeutically to help eliminate the pain, you have to symptomatically Band-Aid or symptomatically help the patient's pain, and there comes in pharmacological management of pain. Talking about pain management, despite the notion that there are so many things that can be done to help pain, it is important to understand that drug therapy is the cornerstone in the management of pain. Since we are talking about cancer, we are talking about palliation, access to opioids for all cancer pain patients is stressed by most societies. So, despite everything that we know, it's important to understand that there needs to be access to opioids to all of our cancer patients. Access to opioids does not mean that you are obligated or you have to give opioids to every one of the patients. But you need to do the assessment and be open to the possibility that that particular patient may need opioids. So pharmacotherapy must be individualized to maximize pain relief and minimize adverse effects. No treatment for pain, and this is something I commonly actually tell my patients in our center, that it's not all about medications. It's about medications along with multiple other things, whether it's physical modalities, whether it's occupational therapy, whether it's relaxation therapy. So it has to be a multimodal approach to pain. I often tell my patients that it's not about always me doing something. There needs to be equal partnership and equal collaboration with the patients doing their part of it. So it's very important to stress to the patients that pain can be controlled, have realistic expectations of how it can be controlled, and make them an equal willing partner in terms of pain management. The difficulty is when we promise pain control and only treat the number and never engage the patient to do their piece of it, that's when we run into the problems of constantly chasing a number and not being able to achieve what we call a satisfactory pain control. So when we talk about pharmacology, these are all the different medications available. Obviously on the corner we have the analgesics, opioids, Tylenol, NSAIDs, both selective and non-selective. We have the adjunctive analgesics, or what is called as co-analgesics. The co-analgesics, the most common one, most of you are probably familiar with, are the antidepressants, the anticonvulsants like the gabapentin, the Lyrica, etc. When it comes to antidepressants, it's the Cymbalta, it's the Effexor, etc. Most often co-analgesics are brought on in treatment of neuropathic type pain. So that's important to know, co-analgesics. And we have other techniques and other analgesics, including topical local anesthetics, topical creams, the skeletal muscle relaxants, interventional techniques, etc. The main objective when you do manage pain is, one, yes, to treat the intensity, to try and decrease the intensity of pain. But I often tell my fellows and my students that it's not just decreasing the intensity, because decreasing the intensity means bringing the number down. But it's not just bringing the number down, it's basically trying to help the patient improve their functional status. So there has to be a subjective measurement of pain, true, but there has to also be an objective assessment of the patient, meaning what was the patient able to do, what was the patient not able to do because of pain, and what is the patient able to accomplish now with adequate pain management. So the key is not a zero pain level, the key is an intensity low enough that the patient can have a comfortable, tolerable pain control, enough so that he or she can do their basic activities of daily living, their functional status, their day-to-day activities without writhing in pain. So it's always important to document and basically assess not just the intensity, but also to see what's the functional status and how the functional status has improved with your treatment. So when we talk about pain, it's always a continuum. It starts from the least invasive to the most invasive. And the least to the most invasive, it depends upon how the patient actually verbates pain, how the patient is actually doing with your least invasive methodology. If the least invasive doesn't work, then that's when you gradually go up the continuum to the most invasive. The commonly prescribed opioids are the following. I'm sure all of you have heard or known or have practiced using all of these medications. We have the immediate release or the short-acting medications, and we have the extended release and the long-acting medications. When you see a list of medications like this, if you are not actively doing aggressive tertiary care, pain management, or palliative management, it's important to just know one or two medications, the ins and outs of one or two medications. All you need is to be very familiar with one or two medications from this list, know all of the interactions, know how to titrate the medications, know the side effects of these medications, when and who and when, how to use it, and that's all you need. Very similar to what people have asked me to understand when it comes to depression, when it comes to psychosis. It's very important to understand that there are so many medications. As a primary care or as somebody who's not trained in psychiatry, it's hard to understand how to maneuver the multiple antidepressants available. And often the suggestion is be fully aware of one or two medications and how to use that. If you're not able to address the symptoms with those, that's when you call in a consultant or send the patient to a pain management specialist. So all I ask is, with these commonly prescribed medications, just to really be aware of one or two medications very well. The more common ones that most of the people use in their day-to-day practice is usually the oxycodone in its isolated form, or oxycodone along with the Tylenol, that's the Percocet. People tend to use morphine, people tend to use hydrocodone, and of course more and more patients are nowadays on Dilaudid, so there is a little bit of familiarity with Dilaudid. So it's important to know a few long-acting, a few short-acting, and know just how and when to titrate it and how to titrate it. So the key principles of opioid analgesic use is to find out if the patient has, what is the trajectory of the patient's pain? Is the pain here to stay, or is the pain something which is going to resolve in the next foreseeable future? For example, post-surgical pain, post-herpetic pain, some of the acute pains. The trajectory when you look into the patient or when you assess the patient is you're thinking the patient might have the pain might have a limited scope, that there might be an end point, that you don't necessarily need to stop the patient on a longer lasting pain medication. If when you assess the patient, for example, this is the patient probably with cancer pain or probably the pain, extensive pain, that there has been a long-standing history of ongoing pain for several years. If that's the trajectory, if you think the patient has long-standing pain or the trajectory of pain is not going to resolve in the next couple of weeks or months, that's when you think about starting the patient on a long-lasting pain medication. There should be no fear of starting a long-lasting pain medication, mainly as long as you clearly understand that if the patient is opioid naive, the starting doses should be opioid naive starting doses. And most of the package insert has given you recommendations of what is a naive dose and what is an opioid tolerant dose. So as long as you understand that, it's important to know persistent pain should always be treated consistently and persistently. So thereby the patient doesn't have a yo-yoing of pain control. Good pain control when the patient has medication, then dips down, bad pain control. A good example is when patients say, I took my medication this morning, I still have pain this in the evening. Obviously you need to know what's the half-life of the medication. You don't expect a medication which lasts for 3 or 4 hours to help the pain 24 hours. So the main thing is consistent control for persistent pain. Second thing is always understand, even in a so-called fairly controlled pain patient, there is going to be breakthrough pain. What is breakthrough pain? Breakthrough pain is, breakthrough pain is basically incidental pain, paradoxical pain, pain which comes on suddenly, wherein you'll need a quick relief of that pain. And breakthrough pain is usually, that's when you use the short-acting medication. So the ideal maintenance of pain, when you talk about pain management, it needs to be an extended release medication for a continuous or a persistent pain. There needs to be an option for a paradoxical pain or a pain which comes on quickly for incidental reasons. That's where you tend to use the immediate release pain medication. And then always understand that when you're starting opioids, patients will need anti-constipating medications because all opioids do cause constipation, so you will need to have a bowel prophylactic medication regimen. So when you write an opioid regimen prescription, it's usually a long-acting opioid, a short-acting opioid for breakthrough pain, and basically something for bowels to ensure side effect prophylaxis. Let me actually stop here and have you ask me questions, because I know the time is limited and you guys have to go. Let me have you ask me questions about pain, and this way at least we could accomplish some of the rest of it is self-explanatory in the PowerPoint. Do you have any questions? Yes.
I have a patient whose husband is a physician, and she has had a destroyed back since she was 16 years of age. She's getting up there right now and is chronically nauseous because of her therapy. And Zofran has helped minimally. Is there any known relief for severe nausea to the point where she's cachectic, losing weight, and definitely into hospice-type material? Is there an antidote for this chronic nausea?
So is the chronic nausea related to the medications that she's on? Is it related to the opioids that she's on, or is she just nauseous because of back issues?
She still has pain, but she's on a big dose of opioids. When they were temporarily reduced, she tried medical marijuana. That has not helped her. The chronic nausea is the main reason that she's continuing to lose weight. So we know pain can cause it. We know medicines can cause it. The only thing we could address was, is there a remedy for medicine-induced nausea?
Yeah.
If I could just interject, we continue